My name is Frances Sakayo. I'm the educator on the Childbirth unit. I've worked on this unit 12 years now. I like the people. I like what I do. It's really a passion. It has to be in order to come do this every day. I knew I wanted to be a labor and delivery nurse when I was actually in nursing school. So when I did my rotation on the unit, I just knew that that's where I wanted to be. I was there probably a day and I was like, this is it. Just be kind of aware of the family member. Sometimes, depending on what's happening here, they may need to actually either be just kind of step them back into like the couch, or hopefully never have to take them out the room. But if it's that serious, we may have to. So as a unit educator, what I do is I find topics that we need a little bit more education on, and I teach to that. Sometimes the nurses will ask me for a certain topic. And there are times where my professional practice leader will tell me, I think we have a lot of this going on. Can we work on some of that education for that? So we kind of come up together as a team. I then send it out to the managers and I say, hey, what do you guys think about this scenario? And so if they approve or if there's something they want to change, then we go forward after that. I'm going to give the scenario. I like to give it to everybody. That way everyone knows what we're dealing with. I want you to know Miss Camila is a 25-year-old G3P2, 35 weeks and 2 days. She's a patient of Dr. Kabir. She's being admitted for a medical induction. What we do is we gather in an area where we can discuss the scenario that's going to take place. We chose to do the simulation about a baby getting stuck, shoulder getting stuck on the pelvis. We found that we're having quite a few of those scenarios while we were having deliveries. And so I felt like that's probably something we need to kind of work on. What is our response to a baby getting stuck? And then what do we as nurses need to do when we're in the room? How do we help the situation and not exacerbate it more? And then we'd have the NICU team give their scenario also and what they are going to be expected to do, as well as go through over team steps, which is our communications. It's how we communicate to each other. Make sure everyone has situational awareness, okay? Anything else?
You talked about closed loop communication. Okay.
All right.
My name is Sabrina Dandridge. I have been at Houston Methodist West for 2 years, and I am the NICU clinical manager. A clinical manager is someone that oversees all of the nursing staff, the ancillary staff, and we make sure that staffing is appropriate and we make sure that the patients that are here get the best care. I've been a nurse for 14 years now, and I originally started as a NICU nurse. That's all I know. I always tell people I do not do big people. I do little babies. That's what I care most about. I decided that I wanted to have a more meaningful impact on the new nurses that were coming into this profession, and I decided to advance my career and to become a manager, and it has been very, very rewarding. So Frances and I work closely together. Within a childbirth center, we all work together and partner together because the mom comes before the baby, so we all have to be on the same team.
And she was 9.5 centimeters, 100% and 0. Sabrina and I have to come up with something that works for both the labor and delivery side as well as the NICU side. So we kind of have to sit down, okay, well, what if we had a 35-week baby come out? Because then we would need the NICU to kind of, hey, I need NICU to show up for our simulation.
When we do simulations, we partner with the NICU team, the labor and delivery team, as well as the mother-baby team. And then when we go into the room, the L&D nurse goes in to monitor the patient. And then from there, it turns into a crisis scenario, and that nurse calls for backup. So from there, you'll see the charge nurse, the NICU nurse, the physician, as well as our respiratory therapist. We all go in to attend this delivery as though we would in real life. And then from there, the baby is born, and you can see the OB delivering the baby. And then once the baby is born, the baby is handed off to the NICU nurse. And then once the baby is handed off to the NICU nurse, we start our immediate resuscitation, emergency resuscitation that we do. So from there, you'll see our respiratory therapist preparing to intubate the patient, starting emergent medication, and our physician coordinating the simulation and giving orders as though they would in real life.
Y'all are in sync. Y'all did a great job.
The benefits is you feel like you've almost done it already, and you kind of have some knowledge as to what it is you're doing. So the simulations help prepare you for when you're in that situation. So you remember, oh, I have to do this, got to do that. So you almost have a mental check off of what you should be doing.
NICU is so niche, and we take care of the smallest babies. And I just love to watch them grow, to see them start off at 1 pound and to see them grow to be 8 pounds and go home healthy. That is just such a rewarding thing for me.
I love getting a baby out. I love helping mom just get to that point where I call the doctor and I'm like, she's ready for you. It's a beautiful thing to be a witness to a mom having a baby. And I'm just lucky that I get to do what I love every day.